My name is Ben. For those who don't know me, I'm one of the AI faculty in this division up the hill in Milanowski Hall. And today I'm going to talk about something called artificial intelligence. You might have heard of it recently. It's kind of everywhere now. And I have a lot of material today, so I want to just jump right into it. First of all, no disclosures. Clinical AI is here. I think that's probably pretty obvious to people. I've done similar talks to this in the past, even just a couple of years ago, where the title of the slide is something like clinical AI is coming, right? But now it's firmly here. It's accelerating. It's being deployed, rolled out across the country, the world, faster than a lot of us can keep up, honestly. I know that there's no way you can see this, but in the middle is sort of like summarizing the capabilities of current AI in the Oracle Health and Epic systems. So I know that every Epic sort of deployment is a little bit different, right? So I'm not sure what exactly we have here at UF. I'd be curious to hear. By the way, feel free to jump in, raise your hand during the talk. I'm totally happy with that. Totally fine with that. But you have things like the FDA now is using AI to screen applications and accelerate the protocol reviews. You have Gemini being rolled out for virtual mental health, and Open Evidence says that more than 100 million Americans are going to be treated by a clinician using Open Evidence. So I'm really curious, but can I ask right now, actually, does anyone here use Open Evidence?
We all do.
Yeah. Okay, that'd be great, perfect. Yeah. Okay, awesome. I think that's
It's
awesome.
just like talking to you. You ask him a small question, it goes for 2 paragraphs.
Well, that's perfect. Yeah. And then if you look at the dates, which I know you can't see, but a lot of this stuff is from just the past 2 weeks even. So things are still accelerating. OpenAI rolled out ChatGPT Health about a month ago. Anthropic released Quad Health, and these are systems and tools that can integrate directly into health records and are doing healthcare related applications. This one was interesting, actually. About a month ago, again in Utah, I found this news article about a first of its kind partnership. It's the first program in the country that allows an AI system to legally participate in medical decision making for prescription renewals. I thought it was kind of a little scary to me, honestly. Even, I'm an AI faculty, and I shouldn't be scared. I should be evangelizing all this stuff, but I think there are some concerns, and I get into that a little bit later in more detail. So because Silicon Valley is sort of like running the show here, is what it feels like. We are moving fast and we are breaking things, right? So this slide is a bunch of the negatives. There's a lot of fear, uncertainty, doubt. There are some, this article doesn't have a date, but it's from a week ago, I think, or Reuters report about, that sounds almost as bad as it gets, right? Botched surgeries and misidentified body parts. Risks, I think we're all familiar with what the risks could be, but we're starting to see these sort of things coming out about real world consequences of using AI. Nevertheless, 2/3 of physicians use AI, and judging from that sort of like informal poll a few minutes ago, it sounds like maybe that's on the low side. I don't know, but the number doubled. This is from an AMA survey that was published last year that looks at the changes between 2023 and 2024 in AI usage and physician perspectives and perception of AI and enthusiasm for AI and concerns for AI. But 2/3 of physicians use AI, and it's a very, very high number for me, to me. And it looks like the top use cases are sort of documentation, billing codes, notes related things like discharge instructions and progress notes and things like that, translation. I guess you all would fall under this one, the summaries of medical research and standards of care, open evidence, things like that. Yes. So this was a question in the same survey about how excited are you about AI, or how concerned are you about AI? The box is not my highlight. That was the AMA's highlight, highlighting that 35% of physicians are excited about AI. The way I look at it, maybe it's a pessimistic way of looking at things, but 65% are at least as concerned, as excited about AI. So there are some concerns, and I think they are justified. So I wanted to take a step back really quick, not spend too much time on what AI is, but I think it's valuable to understand what it is, what it isn't, just a general overview of how it works, because I truly think that the path forward is it's going to involve cooperation between doctors and developers, data scientists, computer scientists. I'm a firm believer in getting medical experts involved in the model development process. So these are the definitions of some of the things that you might have heard thrown around, like artificial intelligence, AI. So these definitions come from this pretty decent AI glossary that the FDA has published on their website. So they refer to AI as machine-based systems that can make predictions, recommendations, or decisions influencing real or virtual environments. So this is much more specific than sort of this a little bit vague definition that's been floating around different communities for maybe 20 years now, which is that AI is anything that mimics human intelligence. So the FDA has sort of made this much more concrete about predicting, recommending, and decision making. Machine learning is essentially the techniques that you use to achieve AI. It's focused on learning from data. Um, you know, with this sort of this diagram here, things that might be considered AI but not machine learning would be simple sort of rule-based systems. And if an input is this, then we're going to make this decision, or if the input is that, we're going to make this decision. Very static and fixed. They're called rule-based systems. Machine learning learns from data, learns complicated statistical functions to make similar types of decisions, but it's based on learning from data and learning from historical examples. Deep learning is going further down the rabbit hole here, is a subset of machine learning that is sort of it's the driver for everything AI these days. It's the branch of ML that uses artificial neural networks. It's the name of the model. But it's very, very opaque, right? It's very hard to tell what's going on inside these models, but they are very, very powerful. And that's sort of the trade-off that you get between performance and transparency and explainability. This is important these days. This notion of differentiating predictive AI from generative AI, because I think that especially among technical people, AI really means generative AI these days, ChatGPT, things like that. Especially since all the tools, most of the tools, I think, AI tools that have been implemented in practice have been these types of generative AI tools. So things that can generate content, right? You can talk with them because they're generating responses to your inputs. They can generate notes and all the rest. Predictive AI is sort of what we used to refer to as AI and ML before this generative AI boom, which only occurred really a few years ago. That's more about predicting outcomes or risk estimation. You can think of that with patients. You learn from the past to make predictions about the future. It's a busy slide, but just really quickly about deep learning. Since this powers both predictive and generative AI these days, these models that are called artificial neural networks, with many different kind of configurations of these neural networks that are used for different applications. I always like including this part in slides like this, which if you understand linear regression, if you turn the equation where you learn a coefficient for each, might call it the covariate, each variable, each input, turn that into a little figure with circles here. You can think of that. I mean, it's a couple more steps to get to a deep neural network. You can think of a deep neural network as instead of one input being a single variable, patient age or something like that, one input here is actually the output of like another regression model, right? And you start stacking them and stacking them and stacking them, and it gets, if you work out the equation, it gets like way too complex for anyone to understand. But turns out when you do that, you have these massive models that are just these hierarchical composites of this type of logistic regression. You can do some pretty amazing things, but you can't really understand how it's working at all. But the thing with deep learning is that it requires lots and lots of data to learn what patterns and signals really matter for a certain application. Natural language processing. Okay, so this set of slides here is sort of walking us through how we got to be where we are, where LLMs, large language models like ChatGPT, Claude, Gemini, and all the others are sort of dominating things. So it came out of this subfield of AI and machine learning called natural language processing. And it's almost not fair to put LLMs in the same category because we all know how powerful these new models are. But they were born here. So NLP is, the subfield here, looking at language, looking at text. It's been used quite often in the past for clinical notes, things like extracting entities. You can see the list of different NLP applications here, classifying text, retrieving information, summarizing. Um, looking back now, it's funny because a lot of effort was spent on these tasks, and very creative methods were developed to do that, and they were all sort of just wiped out by the new models that could do almost anything. Um, Actually, there's a famous AI essay called the Bitter Lesson, and it's about this came out in 2019, actually, so 4 years before ChatGPT, roughly, um, about just commenting on how lots of time and effort and research in the sort of this computational space, creative human engineering to get things to develop interesting things and all that. And usually it turns out when you have enough data and enough computational resources, none of that matters. It's all about scaling. Search and scaling can sort of solve every problem. And some of the, might be spinning your wheels without that. But yeah, lots of different applications of NLP in the past. This list is for critical care. There's a couple applications here involving AKI and other nephrology related things. So the important point with these sort of more traditional applications of NLP is that they all typically involve very narrow data sets, narrow models. So this one model can predict AKI from a patient's H&P note or something like that. And it requires very painstaking manual annotation of the notes to identify certain markers that are part of the hypothesis, like looking at maybe social determinants of health or something else in the H&P note or presenting conditions. Very small data sets, small models, very narrow. Each one is designed for specifically sort of like bespoke for a certain prediction, just totally different from how things are done now, where it's one model that's sort of fine-tuned is what it's called, sort of maybe an offshoot modified slightly for different applications. But a lot of work was done. So this issue or the concept of tokenization is important. So this is how the machines actually understand the texts ultimately. You might have like a clinical note or some piece of input text, your prompt that you're typing into ChatGPT. Under the hood, the model is tokenizing your text, which many times is identifying individual words. It's not that simple because sometimes they'll take chunks, like character chunks, right? So you can see sometimes they'll split like within a single word. But the point is it turns your big text into tokens, and those tokens get sort of like, it gets vectorized, right? I don't want to go too far in the weeds here. But the process of converting text into numerical data is really important, obviously, for a computer to understand it. So LLMs, all that they're really doing is encapsulated in this tiny figure here, and that is they're predicting the next word, essentially, next token prediction, right? The sky is goes into the model, and under the hood, internally in the model, it's coming up with sort of the top 5 or top 10 or top 20 words that make, or tokens that make the most sense to follow the sky is, right? It assigns a different sort of probability each of the next tokens, and typically it would output maybe the one with the highest probability, which is blue. The sky is blue. But you can control that with things like temperature, if anybody is familiar, where sometimes you inject a little more randomness, so it might go down the list a little bit. The sky is usually, and then once you have the sky is usually or the sky is blue, then that goes back into the model to generate the next word, right? So it does that iteratively, and that's at the end of the day, that's how these models are working. And the magic is that when you apply trillions of you basically apply the entire internet, the history of the internet online, all text from humanity, all digital text, with the amount of like computational resources that are currently available from these billion, trillion-dollar investments. Some pretty interesting things occur. But we'll get into that in 1 second, actually, right here. So That's what happens when you train these models on internet scale text data sets for next token prediction. And some people refer to the things that kind of arise from that as emergent abilities. Sounds a little like sci-fi scary to me, but you see here, this is the number, this is model size on the x-axis here. You keep increasing the model size, making it more complex, essentially. Nothing's really happening, but at some point, suddenly the model can do 3-digit addition out of nowhere, is what it seemed like. Same with other tasks like that. And this figure is actually a little old now. It's ancient in AI terms because it's 1 year old, I think. But it demonstrates the purpose pretty well. These emergent abilities are things, like even interacting with users. That's an emergent ability. They can use tools. They can follow instructions. They can sort of do whatever you want them to do. Answering questions, being like a knowledge bank. That's all emergent. You could think of going back here. The input could be, the capital of Florida is, and it would give you Tallahassee. That's sort of answering a question there. But that similar concept can be applied to lots of different abilities. And I think we're familiar with quite a few of them. Immediately following the release of ChatGPT and still to this day, there has been an explosion in the amount of AI research involving these LLMs. Initially, I think all 6 of these are sort of claiming that ChatGPT or other LLMs can outperform physicians, which I don't like to take that approach at all. But I think there was some excitement, some awe that they were even able to get close because this sort of came out of nowhere to a lot of people. One of the canonical tasks here is medical question answering. So this is a popular benchmark that measures, so the benchmark is a collection of questions from the USMLE exam, right? Step 1, step 2, step 3. And that was always the benchmark over the years from 2022 until recently. You had some open source models, you had Google's MedPalm, you had OpenAI, GPT. They would kind of jockey for position back and forth, leapfrogging each other. And then last August, Open Evidence claimed that they achieved 100% accuracy. So I guess the game's done. You can't get better than 100% accuracy. So so that's pretty great, I think. Scary, both. I don't know. I will say that there are some issues here. I mean, there are concerns because these models are sort of vacuuming in all the data from everywhere that, and it's such a popular benchmark, it might have been ingesting like the test questions ahead of time, potentially. That's an issue these days with AI models. When you're evaluating on a benchmark, you want to make sure that the benchmark itself wasn't included in the training data that it already saw, because that's cheating the test. So building on these text-only QA models or text-only LLMs, a lot of research these days is involving this idea of multimodality. So adding imaging, signals of all kinds, omics of all kinds, different types of data. Different types of imaging, dermatology, mammography, radiology, pathology. Just sort of integrating all this different patient data to arrive at some kind of data-driven representation of the patient that can be used for lots of different downstream applications, with sort of the goal being this AI-generated representation of patient health, where somehow the AI understands like the snapshot in time of how the patient is doing, maybe can forecast trajectories, but crucially can be interacted with natural language from physicians.
Ben?
Yes.
Sorry to interrupt.
Yeah, for sure. Yeah, love it.
I have a question about the last slide that you were saying, the USMLE.
Yeah.
So you were talking about predictive AI models versus generative or narrative. So the predictive models, can they be used in general platforms like Open Evidence or ChatGPT, or they have separate licensing? Because my concern is that they made like the AI take USMLE. Can someone use AI to predict the next USMLE question paper, for example? Right?
Yeah, that's a good question.
Yeah,
I love that. Potentially.
if it is available to everyone and free to everyone, like, I'm sure people will not stop at experimenting. Or is it something that you need to have another license? Or, how does it work?
No, I think that one of the issues with AI, in my opinion, is that it's available to like anyone. There aren't that many barriers to entry, honestly, because even the open source, the free models, someone can download and run on their own computer at home and won't even know about that. I'm not sure your concern with the USMLE is that students might be able to predict what the next questions would be.
Just curious.
Yeah, maybe for sure. Yeah, I mean, so this isn't trained on actual exams. It's from test prep and other things like that. But I think it's meant to be like a pretty close representation.
Because these exams have they have coding, like they pull certain number of questions from each topic, and the pool coding changes like every year. Like we're gonna have I'm more involved in the ASM in training exam. But I know that they'll pull like 5 questions from this topic, 6 from that, and there's a blueprint for it. And that's how
they might find out, like, discover the blueprint.
No, not discover, but they may. I don't know if they can have like look at the trend, use that to predict.
Interesting.
But don't they need the actual question to predict?
I don't know how.
Because the question is not in the. This is not accessible. Right?
This data set is like it's
Okay.
fixed. It's fixed. It was fixed a few years ago, and they've
Yeah.
been like adding to it every year with like each year's questions. They're not doing that. So just
Actually, yesterday we received an email that
Yeah.
American Board of Internal Medicine told us if then we are not allowed to copy paste the questions into the. I think that's for this reason, because when they have access to the question, that might predict not just the answer, but the next question.
Next question.
Yeah, that was actually my point. The USMLE questions are not that unique. Even when I was taking my shelf exams, back when I was, medical student and resident fellow, I recognized the questions from the question banks. There's a little bit of tweak in them, but very minor. But with the age and a little bit of story, but it's very, very simple. Right? As question writers, it's not that, there are not too many units. So I can understand how this can happen. Right? I wouldn't say this is cheating, but if you go through a similar question a couple times, you can score really high. I mean, it's not super rocket science.
Yeah, is that a
Because
problem?
there's a set. Yeah, it's just pretty piece.
Well, I think this is just an expansion of what's going on, where you have top number of test centers available, so it's just expanding that to a bigger.
It's an issue with the
Yeah,
test maybe,
so
right?
so I don't know, if they're allowed to offer test prep, some question, and this is just better than them in presenting potential questions.
You see, Ben, before your talk, we were more interested than concerned. Now we
Yeah.
started to be on the other side.
Question, right? And if you're a resident or fellow familiar with them, you score high just because you're familiar with them. So I don't think there's any difference here, right? It's not that you have inability. No, you just know who calls these forms.
Yeah, maybe it's time for a new test then. I don't know. I don't know if that can words.
Has to reframe the whole mindset of it.
The issue of sorry. Yeah.
No, I'm just wondering, like, I'm not sure, it kind of, there are patterns in the way we do everything. That is, human nature, and that can be predictable sometimes. So I'm just, intrigued by it.
Well, no, patterns are survival mechanism, right? You learn something that works and you repeat it subconsciously.
Yeah.
It's good for AI.
And your AI will feed on it.
Okay.
He wants to do it.
Okay, so going back to multimodal question answering, you have this application category called VQA, visual question answering. So you can sort of chat with models about an image, and I'm not sure if that functionality has been deployed here at UF or not. But this is showing example of pathology and also radiology. And I'm not a doctor. It seems pretty impressive to me, but I think there are some. I'm not yes. Yeah, I'm not sure exactly what's going on here, but I assume because they put it in their paper, it's probably they're highlighting something impressive. But sort of like asking questions about the the image, and it's able to generate something that apparently seems reasonable or seems pretty good. Sort of just selfishly highlighting some of our own work here, looking at multimodal tokenization of EHR, mostly structured data and clinical notes, so no imaging, tokenizing different lab tests, vital signs, procedure codes, social determinants of health, demographics data, and eventually extending that with omics and biosignals from wearables and video and things like that. So this is a very active space in the AI and healthcare domain. This is some work from one of my former PhD students who was also a surgery resident. He graduated with his PhD in biomedical informatics over the summer, and very impressed with this work that he was able to put together, looking at LLMs for essentially for working together with physicians to screen data. The first project was the system where you could chat with operative notes to ask questions about the surgery, and he was focused on extracting sort of markers of surgical technique, which is a little bit qualitative, but sort of making that more quantitative so that he could it would enable some downstream analysis for sepsis rates and other things like that. We developed a system for AIS, which is the assistive, or it's the abbreviated injury scale, and a way to screen patients and to sort of identify or flag discrepancies with human coders, sort of this co-pilot for doing that, not meant to replace, but meant to work together. This issue of data leakage in LLMs is interesting. It's a paper that's ongoing, almost finished, but the issue of copying and pasting. I mean, all the guidelines in the world that UF Health imposes on AI and whatever systems they say are allowed to use and put in Epic, everybody has this computer in their pocket with whatever they want, like Claude or ChatGPT, and people are inputting things sort of like under the table, right? Or like off book a little bit. So it's really tough to tell. It's just become such a daily part of everybody's lives. It's very interesting. But copying and pasting information, theoretically, once you put that into a model, it's there. You have to assume that the company would save that somewhere. So you don't want to put in some patient data, some PHI that somehow can be leaked with some malicious actor or bad actor, sort of like trying to get it to leak PHI that's somewhere in its training data. Lots of interesting things here. And I think the current regulations and guidelines for protecting patient privacy aren't really ready for this kind of new technology. And applications are still emerging. I mean, there's just a new paper every day. I mean, multiple a day, but the new landmark paper every couple of weeks. So it feels like looking at EHR, generating basically translation, but for machine language. This fast healthcare interoperable resources, the FHIR format for sending health information among different systems, matching clinical trials, virtual assistants. I mean, there's lots of different potential applications of this AI technology. But what is really being used right now, and I think you probably all know better than I do, you all are using it, but 68% of physicians say that, it's going back to the survey, 68% of physicians say that AI is an advantage in patient care, so that's good to see. How will AI help was the question, and people responded with, more efficient work. Diagnostic ability was interesting to see so high. No change there from the year before, but 72% of physicians saying that it's going to help diagnostics is pretty interesting. That's more in the space that we work in, as opposed to helping with documentation, things like that. Stress and burnout saw a big jump there for whatever reason, maybe because they've seen the benefits of that, similar to cognitive overload. That's interesting.
It's good with stress and burnout. I don't understand that stress and burnout or the work efficiency increase.
I don't either. I mean, this is from the AMA survey. This is not a work that we did. I'm not sure how they define that. The question was above. The AI tools be somewhat very helpful with following factors, and I think they selected one or more factors. I don't know how stress and burnout is different from other things like that.
So it is helpful with the stress, right?
Yeah, that's what it's saying.
But in breathing.
Why not take the most, for example, if your work efficiency goes up, so
It's
the harder it
related,
will
right?
be.
Yeah.
But it's the opposite, that's went off like 10%.
No, it's saying it can help with
Some
the,
work
it can help with stress and burnout, it can help with work efficiency, it can help with cognitive overload. But I think this feels like a more sort of like hypothetical kind of question.
I've seen that like
Yeah.
some, I don't know if this question was like in general AI, but clinicians not here, but outside of UF, they're using a lot this like program that you leave your microphone on while you're talking to your patient and it writes the notes.
Oh, yeah,
for
you
you.
want it's like the,
Yes.
yeah.
Yeah. And so I know that that's helping a lot. I would feel that it would help me. Like if you get burned out from writing a lot of notes daily, I would get more than 10 hours.
Do we have that here?
Oh, yeah.
It's only this. But if you work with a faculty that has it, you can see how it works. You actually has, but the Shickel has it, I have it. It's a little bit wordy. It just tells you a lot of stuff and you don't need.
Yeah,
It's great for the coder.
Yes, great for the course.
Because then they'll be like, I cannot read anymore.
So I'm just letting you find out.
I have some concerns about that, they'll get into in a second. Is that billed as ambient AI here?
Yes,
That's what I've seen.
Yes,
Yeah.
exactly.
Yeah. So in terms of real world, as of, I mean, a lot could have changed. I think the survey ended in 2024, late 2024. Translation services, I mean, you see the documentation, that sort of thing is so the dark blue is what they're already using, or maybe like will use in the next few weeks or something like that. Then the next bar is for the next year, next 2 to 5 years, 5 to 10 years. So as of well, geez, maybe like a year ago now, end of the survey, it's those that they were using currently. But if you forecast out next 5-10 years, I mean, it looks like it's got to be almost 90% for most of these will be using AI in some capacity for some type of application. This was a recent study just showing that sort of physicians who use ChatGPT in this study, or physicians who use AI, basically are higher than physicians who use conventional resources, they called it, which I think was pretty much like Google or up to date. And the physicians who used GPT outperformed the conventional resources, but they took a little bit longer on these sort of expert curated clinical vignettes. So whatever that's worth. I don't like to look at the other bar they included, which was GPT alone. It's almost the same as the physician with GPT, but that's interesting. I mean, I feel like that's sort of like where this is headed. It's not GPT to make decisions, but it's physicians who can use it as just one other information source, maybe to help.
When they use GPT alone, like in what terms? Like,
yeah, I mean, it's a good question. I think they laid out like all the technical details, like in the prompt, because yeah, people can go back and forth, right, with it, and how do you simulate that with just a machine? They make the decisions on that. It's something there. The question was, how do we increase trust in AI? Because I think that was a big concern for not only physicians but patients. I don't think I included. I cut a slide about how I think such a very low percentage of patients say they trust doctors to use or trust hospitals or health systems to use AI for their benefit or use it responsibly or something like that. But how do we increase trust? Most people responded with increased oversight, similar to that. And I have bad news for them. I'm going to put slides, but yeah. So we'll start with who is developing AI. It's not us here at UF Health. I mean, we're sort of researching interesting things, new types of AI, new applications of AI. But the AI that you are working with, it's developed by the big names up there. It's developed by industry, who have pretty much stopped publishing, right? Before the whole, before when every idea could be worth billions of dollars, they would publish papers, they would open up their models. There were big research communities in open AI, named Open. Google was big, Meta, and all the rest. But they sort of close that off now. So it's very difficult to even tell how the models are working or what even data was used to train the models. You have concerns about copyrighted material and other things like that, PHI that we have a concern there. But essentially it's industry, so that should be concerning, I think, to all of us. And again, sort of like a goal of ours to get as many healthcare professionals into that development process as possible. Simple plot, kind of like following similar trend here, FDA authorizations by year, it's just going up and up. By specialty here, most are radiology. I would expect that to go down pretty significantly. Most of this still is from pre-2023, pre-ChatGPT, pre-LLM, that sort of thing. So moving forward, I'd expect more to be in other fields. So that's more like imaging AI, a little bit different from the other generative AI. This was a study from a while back. Well, I say that, but it's a year ago essentially, showing that a high percentage of the FDA authorized AI applications didn't include any validation data whatsoever. So very difficult to trust them, right? And as of, this was a month ago, right? January 6th, 2026, they've lowered the bar even more, laid out some criteria for what's considered a low risk or non-device AI. So in the beginning, every AI system was considered a medical device and regulated accordingly, according to those existing rules for medical devices. Slowly, it's been shifting, and now it's pretty much just open the floodgates for any like generative AI type of an LLM type of application to kind of skip all of the pesky requirements of getting something into your hands. No pre-market clearance, there's no surveillance, there's very little or no oversight. And of course, that's meant to enable Silicon Valley speed in healthcare, which I guess we've been sorely missing. I don't know. But yeah, essentially, things that the criteria is a little it's pretty reasonable to me. I don't know if you can see, but it's it has to provide a recommendation instead of a mandate. It has to be transparent, and the wording is a little vague, and I think they're expected to clarify that in the coming weeks or months. But this is a new development that I think is a pretty big deal, and I think you might be seeing even more of these different LLM-based tools in practice. Okay, so this is a very important thing. This came out a while back. Actually, it's still preprint, so it's going to come out this year. It's going to come out soon, and I have a feeling it's going to land somewhere big, like Nature. A lot of authors. It's analyzing LLM safety, which hasn't really been done too much, unfortunately. Specifically, LLMs that generate medical advice or support decision making. And so the authors here sort of developed this benchmark called no harm to evaluate the safety of these recommendations. And they looked at 100 real world cases that they recruited experts across 10 specialties who provided 12,000 annotations for different things as to whether certain recommendation was appropriate or safe or, too vague maybe, or other sort of dimensions there. What they found is that the potential for severe harm LLMs occurred in 22% of cases, which is a pretty high number.
Yeah.
And the thing that I thought was most interesting, though, is it's mostly this harm of omission, right? It's not that it's hallucinating a fake medication or anything like that. It's not including something that should have been included, right? That's much more like insidious, in my opinion. It's hard to identify those errors unless you already know what the answer should be. So being wordy is a problem, but also missing the right words is a big problem as well. But wow, 22% resulting in severe harm, however they have defined that, seems pretty alarming to me. Yeah.
I do find, so if I actually look at the length that it's citing, it's misinterpreted very significantly. Right? It gives the answer, it's like yes or no, right? That's the first answer that you get. And then I think it's just a matter, and then also over 90% of people will not look what it's drawing info from and how. I don't know. I think the more you look, the more you know.
Interesting.
The more it becomes interesting, yeah.
They also showed actually that safety was only like moderately correlated with medical knowledge benchmarks like the USMLE that we just talked about. So even if a model scores well on the STEP exams, it's not, that doesn't mean that it won't generate severely harmful medical guidance. This shows sort of like among specialties. I included this because it mentioned nephrology explicitly. That was one of the 10 specialties. They looked at the advice generated by these LLMs, and they had three real physician experts sort of indicate the harm level. And the dark green on the left are sort of the examples where all three experts agreed on how harmful it was. Then you have, going further to the right, that nobody agreed. That's on the right. I think that it's interesting to me. Nephrology and endocrinology, I guess, are sort of had a low number of perfectly concordant harm ratings. So people sort of disagree a little bit on how harmful the advice was. I'm not sure what you take from that.
And it goes with our personality. We are very critical of it. Exam, critical of LLM too.
And I don't want to unconsidered, but these are traditionally the cerebral specialists.
This is interesting too. I mean, so they have potential for generating harmful advice, not unsafe advice. But they looked at 31 different models. The best models were actually more safe than humans, according to their benchmark. The worst models were much worse than the humans, but that was interesting as well, right? It's an idea that you can extend to a lot of different applications here, where humans aren't perfect either. Right? So if a machine makes a mistake, and I'm not like defending the machines here, but humans aren't perfect either. So maybe we shouldn't be demanding perfect performance from the machines, but then you have issues of accountability and responsibility and lots of other things. It's very interesting. It's an evolving field for sure. So they found, I'll just add this as an addendum here, they found that this agentic AI, I don't know if you've heard of that recently. I have a slide later on that. I don't know if we'll get to it, but agentic AI is essentially you have like one LLM. You could consider that an agent. You could have another LLM, multiple, talking with each other, working together as like separate entities, and they can, they label the roles as advisor, guardian two, to sort of like fact check and double check, and they found that resulted in more safer advice more often. This is interesting to me. I don't know. It's more of like a theoretical exercise of how you could poison the training data, like intentionally. If you have malicious intent, you could inject like medical misinformation on purpose, because everybody knows sort of like where bulk of the training data comes from in these models. You could inject some misinformation, and they should relatively easily have that work its way into the outputs from the devices, from the models, who I think already struggle sometimes with like accurate information. But this is sort of just a little bit concerning to me. But I'm not sure how realistic of a concern that might be. Okay, so I'm sort of like closing the book on the LLM part of the talk, or the generative AI part. So this is the predictive AI part. So that hasn't gone away. It feels like it might have, because when people say AI now, they usually mean the tools that we've been discussing so far. But I think ultimately what this is going to look like, AI in healthcare, AI in for acute care, critical care, nephrology, it's going to be some combination of both. And where you see that happen is in this agentic AI framework, where this like coordinating LLM, your friend Claude or whoever it is, will be able to access the predictions from like one of these traditional tools or risk predictors, risk estimators. Pull data from the EHR, send it to one of these prediction tools, do something, send an output back to the person. This is sort of like large interconnected agentic framework, I think, is sort of what the future is probably going to look like. But this was a review from a few years ago now, showing different applications of AI in nephrology. And I think all of these are more along the lines of that predictive AI, using numerical data, predicting into the future, which is, I think, kind of like orthogonal. It's kind of different from the LLM applications. AI has benefits, use cases in critical care for early identification, real-time, sort of more autonomous monitoring that could be helpful. When data comes in real time, it could raise a flag to buy precious time. This does not involve asking the AI like what should I do, or like what does this look like to you, or whatever it is. It's going to be happening in the background from pattern recognition and the numerical signals, the vital signs, other things like that. But lots of different benefits, I think, for especially in these high pressure situations, environments like critical care. This was an interesting slide. I think there was this big, highly publicized model. It was now 6 years ago or so from Google DeepMind about predicting AKI, and it showed this like superior, like just astounding performance. But then when people kind of like looked under the hood a couple years later, they saw that like predicting tomorrow's AKI stage, or actually 12 hours ahead, it was like pretty much only based on the current AKI stage, which is, I mean, that's how it works, right? Like if a patient is AKI stage 1 now, they're likely to be stage 1 in an hour, right? But it sort of like inflated the performance results a bit. And it just shows kind of the importance of transparency, explainability, like how is the model making decisions, just super, super important. Animation from this. Just more examples of continuous monitoring. This is sort of the space that I also work in, so these slides are a little bit selfish as well. But looking at continuous monitoring, ultimately for real-time deployments, which we're actively working with UF Health IT and others to deploy these things and enable sort of real-time predictions that would show up to you guys. I think it's like a flag in the EHR in Epic or something like that, telling you what to do, but just sort of saying, hey, like, take a look at this thing. Doing more work here in similar types of thing for surgery. So looking at intraoperative time series, looking at what the most important predictors of different postoperative complications are. We're looking at uncertainty quantification, which I think a lot of people are asking for, which is, the model can make a prediction, but how confident is the model in that prediction? You really have no idea. So we're trying to quantify the uncertainty with methods like conformal prediction and others that are designed to do that, and sort of like equip models with the ability to say, I don't know, which is not there currently. Like it's going to tell you something, right? It doesn't want to disappoint you. But I think like having that capacity to say I don't know or something, or disagree with you, for God's sake, that's really important, I think, for this more effective like real world AI deployments. Similar to before, we're doing this multimodal EHR tokenization, looking at structured data elements like vital signs, lab tests, medications, others, sort of like compacting all of that together, tokenizing that, developing these universal snapshot instantaneous representations of a patient, which we're using for predicting outcomes like postoperative complications or AKI or mortality or what have you. We're looking at this multimodal integration of text now, where we sort of like use the discharge summary to help the model frame everything it saw beforehand in terms of the discrete data elements, which worked very well. This cross-modal fusion, so something we did that we're excited about now extending with imaging and other types of data. Final few slides are some of the more futuristic, maybe, or like upcoming on the horizon type of applications of AI in acute care. So this agentic AI, I talked about it briefly. This is how this is how we're going to see the combination of generative AI, predictive AI, non-AI tools, databases. Like this is coming. This is probably already integrated in some capacity, but it's this idea of agents who can act autonomously, which again, a little bit concerning to me. But that's what makes this an agentic AI framework, is that each, you don't have to sit there yourself and tell the system what to do. Like it knows how to do what you want. It knows how to break down your request into multiple sub requests that get routed different ways. Anyway, it's kind of complicated. But this is coming and get ready. Digital twins, we're doing digital twins in a few different ways. So this first is a collaboration with Dr. Bjork's group. We got a seed fund award for this. We developed this digital twin of the ICU and going to sort of deploy this for simulating different work activities or patient experiences, maybe arrangement of the environment and things like that. So that's pretty cool. My former student Jeremy Balch and I worked on this digital twin of OR instruments. So he's interested in tracking instrument use in the OR on the back table, and it was very difficult because of the overlap and other issues there. But he actually put cameras in there, collected data of how often these are used to try to make the instrument usage more efficient, because maybe like half the tools don't even get used at all, but they all still get cleaned and everything like that. So maybe like tailoring the tool distribution per surgeon based on their preferences and other things like that. But he was awarded this Rapids grant for this. And on the right here is the method that he developed using what's called Gaussian splatting. This is a 3D recreation of one of the tools in his home office, I believe. Sort of using images from his phone, it reconstructed it and turned it into this 3D model that we can use in our simulation engine. We are also developing digital twins at the patient level. So specifically in this NeuroDigit project, which looks at the neuro ICU, sort of simulating simulating outcomes for different interventions using multimodal engines, the drivers that we developed for other projects, to predict what would happen if we gave patients certain medications now. Should we wait? Should we intervene? Bringing neurosurgeons, then sort of answering questions like that, simulating the flow of patients in the neuro ICU. And we're integrating lots of different types of data here, from structured EHR to notes to waveforms to medical imaging. And I believe this is my final slide, and just highlighting some other things, working with Dr. Sarter on few projects actually, looking at this multimodal digital pathology. And one of them is very exciting, this multimodal AI initiative with NIH, the OT2 grant, and very, very exciting grant looking at the CKD longitudinal prediction using structured EHR, like from Epic, and clinical notes, and omics, and radiology, ultrasound imaging, integrating all of that together for more precise CKD trajectory monitoring. Another one that's one of my newer students, who is an MD PhD student. So we're looking at, sort of going back to midway through the slides here, a natural language interface for accessing a patient's health information, maybe history as well. So that's pretty exciting. And then I just want to plug our AI Passport program. You might have seen like a million emails about this over the past year or two, but it's pretty accessible introduction to AI, designed for people like you all, I think, to learn the fundamentals of AI, what it means, how it works, without much, with no coding background required, no math background required. So just a way to start upskilling the community to learn about like all that, the whole AI landscape, not just the one tool that you use every day. So that's pretty important too. So I think that's all I have. So any questions, be happy to answer.
So have you seen, and I think it might be too early for this to happen, any kind of legal cases, lawsuits? It's just like when GPS started. I mean, it's overwhelmingly helpful for everyone. But there are cases followed GPS, follow a cliff or a bridge that's cut off and died, and the families need. So things like that can happen. Has there been some kind of issues?
I looked for that. I looked for that. The best I found was that one of my first slides about botched surgeries. I assume some lawsuits are coming on that. I mean, it's very, very, very new. I don't know what happened in the GPS case. Like,
no, what I'm just saying is, it's you see this news.
well, I know.
Right?
I'm curious if like GPS developers are they at fault? I mean, I think no one really knows the answer yet to some of these questions.
I think it's just too early, but how people can be creative to make any close out of anything, so it will not be far from.
Like if the AI tells you to do something, you do it, and it was the wrong decision, or
If your family knows that most doctors use it and try to blame it, because somebody dies and they say, oh, the doctor or my doctor relied on AI, that's why they made the wrong decision and gave the wrong medication.
what if you didn't? What if you didn't listen to it and they determined that it was the right? Like can't win. I mean, I don't know. Like,
No. I mean, in our world, lawyers, even if you have not done anything wrong, people can be so creative to make a case just to get money out of it.
Like for example, DAX nowadays, like I think we had this discussion in the clinic, so it transcribes whatever you talk with the patient. Now, let's say that, something that is not mentioned in the note, can like they go back to the transcription and like get subpoenaed for this or no? I mean, I don't know if there are any rules right now.
The last note generated note gets deleted after 24 hours.
I think they said 30 days. But I'm not so sure. That's why I'm not so sure. Like, does it get like saved somewhere because it's there, or does it like permanently
I
get
don't
deleted?
know. If it were me, I would assume it does. Just
Yeah, everything.
Like say,
Yeah,
right?
has digital footprint somewhere.
Data is money these days, right?
The AI reading a report like is really hard from the climate. So it's a lot of cooling with that.
That's real. Yeah.
They say if you use please, it costs how many gallons of water?
Yeah.
Please and thank you and all that.
Yeah, I mean, and that's one of that's terrible, right? And it's like, is it even worth it, right? There are some, I think, definitively positive use cases for AI. Europe AlphaFold, looking at protein folding and things like that. One of the basic science side where it's been used. They won the Nobel Prize for this a week or two ago. The clinical AI stuff is, I think it's the verdict is still out, jury's still out. Do you all think that it's helpful?
I think it comes down to liability. We are all trying to be more efficient and, ideally go home a little earlier, right, than late in the day. But who's liable? Then, if all of a sudden the administration they decide that we can do even more work with the help of AI, but we have to double check everything after it, that becomes how we see it in clinical. The patients come and they say, right, they're limiting phosphorus and CKD3A, and all of a sudden phosphorus is low because they think that's what's causing chronic kidney disease, but they misread what they,
Yeah, well, it's a whole other can of where like the patients are using it. It's the second guessing and everything.
That's stage disease, that's the one.
Yes,
It
I saw the first now.
I feel like it's, until it settles a little bit, it's going to be a lot of
That's
confusion.
That's with costs too. I mean, these companies are hemorrhaging money. I mean, no one's making money with this. They're all banking on the future. They will turn a profit at some point, but it's when is that going to happen, if ever? If it costs this much to run the model, that I can't see that being sustained. Really nice in that part.
We've not gotten into this stuff in the area of research, sometimes I use it just to find codes, how to make graphs and plots in R. And sometimes it's so meddlesome because I'll write to the discussion of this. I mean, I offering to write to even the response to the reviewer. I'm not acting to do that. And they're telling you to tell the reviewer you did simulations and this is the best model. I did not do that. Why are you telling me to do this thing?
Yeah, they have tendency to do that. Right?
Yeah, I mean, that's putting words into your mouth that will get you in trouble because I did not do that. You want me to lie to the reviewer. I didn't even ask you for that.
Oh, you just take some previous work and copy that text.
Thank you.
Thank you.
Thank you.
Yeah.